Oh, I'm live. It's happening. Okay, here we go. I'm gonna do. Let's see here. Okay, I'm gonna do a video here about a little story time, I guess. So I thought it'd be fun. Come in and talk about Code Blue situation I had one time in the ER. So this is not a story about the cath lab, but it should be. It was interesting. It was eye-opening for me, and so I'm going to talk about it. Hopefully this isn't too loud. I guess I will never know. So, all right. So the story starts. So I'm an ER tech at this time, and the ER tech is responsible for compressions and pulse checks. We do pulse checks, and we do, we'll do a little bag valve mask ventilation, BVM, the bag. We'll bag them. I never defibrillated as an ER tech. Never got to defibrillate. I had to defibrillate all the nurse. Lots of pushing the shock button. No pushing the shock button as a tech, I guess. But you get them on the pads and get them on the Zoll. Anyways, story goes, I'll try and be as hip and compliant as I can. Won't tell you where or when, so if you don't know where and you don't know when, how can you, know anything HIPAA related? All right, so what happened was, patient came in for stroke, code stroke, coming in. I guess she had like one blown pupil. GCS, Glasgow Coma score was 8-ish. Not responding, not really responding. She didn't look good. And they were thinking it was they didn't know what kind of stroke it was, but she was normal, and then it was like, boom, she was like zonked, kind of posturing, and she had like, I think she was kind of, I don't remember. She came in as a stroke though. She came in as a stroke, she wasn't responding, I remember that. And because of her Glasgow Coma score being so low, oh no, terrible echo. Oh no. I don't know how to fix my echo. Let's see. Can I hear myself? Oh no. I don't know how to fix my echo. What if I turn this down a little bit? Let's see. Can I hear myself? Oh no. I don't know how to fix my echo. What if I turn this down a little bit? Let's see. Can I hear myself? What a freaking nightmare. Well, this is just how it's going to go, unfortunately. So I got this crappy mic. This is all I have. So I got to, I don't know, man. I don't know what I'm doing. So, patient came in as a code stroke. I'm on the code. So if they're a code stroke, and you're the tech, the ER tech, you're going to get them, cut their clothes off or get their clothes off, however, get them on the monitor, get a blood pressure, get a set of vitals, get them on the Zoll because they're going to need to go to CT, right? Because, you need a non-contrast CT before you can give your TPA. So, and you got to transport them on a Zoll because it's a critical patient. It's like an ICU patient. So, you know what I think the echo is? I think it's just this big friggin' room I'm in. I'm in this big giant room, and I have no, let's see if I can show this. No furniture in my basement. There's nothing here. It's just empty. It's just an empty basement. That's all it is. It's an empty basement. Oh, Lord have mercy. So that's not working. I need to screw this out of here. Code strokes. So you have the code stroke, you get monazole. You want to get a 12-lead EKG as well, because if they're in atrial fibrillation, that's a thing they're worried about. They're worried about a bunch of other stuff with their EKG. So you get an EKG, get them monazole. This is just our policy at the hospital I worked at. EKG, get them monazole, get a set of vitals, get their clothes off, put them in a gown, and if they need oxygen, give them some oxygen. Anyways, doctor comes in, he's like, don't like her GCS. I don't like how, she's not responding. She can't protect her airway. Not that she was able to protect her airway. No, she needed to be intubated. But instead of intubating with like a glidoscope, which is has a little camera on it. It's like a nice fancy doodad, plastic. It's got it looks like a Mac. Looks like a Mac blade, and it's got a little camera on it, and it's got a little cord to it, and you can see the cords on a camera sitting right next to you as you're placing tubes. You know for sure that you got the tube. Well, this doctor, oh gosh, so he's like, he looks, first he looks, right? So we're doing something called a RSI, a rapid sequence intubation. This is where we push a paralytic, right? Before we push the paralytic, you're going to push like some kind of sedative. So a lot of times you'll push etomidate or ketamine or propofol or Versed and fentanyl, or you'll push something. Usually it's etomidate, but I've seen it all kinds of different crap we've done. Generally in the ER, it's like 20 of etomidate and 100 of rocuronium, or however, I don't even know for how much freaking sucks. You would get, what is it, like 1.2 milligrams per kilo? That's a good thing. Let's check that out. We'll look that up. Succinylcholine. Succinylcholine dose RSI. Succinylcholine dose for RSI. Optimal dose 6 of rapid sequence intubations. I thought it was 1.2 milligrams per kilo. Yeah, 1 milligram. Induction, 1 milligram per kilo. So if they're 100 kilos, give 100 milligrams. Conclusion. With succinylcholine regimen 0.5 milligrams per kilo, excellent intubation conditions are less likely of, and apnea times are shorter compared with 1 milligram per kilo. With 0.3 and 0.5 milligram per kilo, unacceptable intubation conditions are more common. Succinylcholine 1.5 milligram doses not produce more often excellent condition compared to 1. Okay, I'm used to 1 milligram per kilo, pretty much. I guess, so I don't know, the point is, back to, I'm a little tired right now. I'm drinking my sleepy time tea, so this is sleepy time story time with me. So he's looking at the airway. He's like, I don't like it. Like, he looks. He's like, okay, he didn't even look. This happened. He like felt her neck, right? He's trying to feel for some neck. There's a lot of neck rigidity. Her neck was really rigid. And he's like, I don't think I'm going to be able to get it. It's like, dude, if you don't think you're going to get it, why are you going to try? I mean, okay, go ahead and try, but use all the tools. Use a bougie. Use a glidoscope. Don't just go in there and throw the tube blind. Like, that's basically what he did was he's checking with his left hand. He's placing the tube. He puts it in, and he goes, I don't think it's in. So he doesn't think it's in, but he's going to leave it, and we're going to bag it. Why? I don't know why we're going to bag it. So I'm sitting there watching this happen. I'm like, okay, so, you have to. Now you have to bag him, because before he intubated, he's giving etomidate and he's giving suck. So the patient's paralyzed. You have to bag him, right? So he puts the tube in. He says, I don't think it's in, or I don't think I have it. I think that's what he said. He said, I don't think I have it. He thinks the tube is in the stomach, not in the trachea, right? It's in the esophagus, not in the trachea. He didn't pass the cords. That's what he thought. So he course, he puts the bag on. RT starts bagging, right? RT is bagging. And what happens? The heart rate starts to go down. So you see like, it's at like, it was high. It was like at like 90, 95. And it also is like 60, 40, 0. And all of a sudden, oh, she flatlined. Well, gee, I wonder why she flatlined. So what's one of the H's and T's, right, for the ACLS people out there? What's one of the H's and T's for an asystole or PEA arrest? Hypoxia. One of the H's is hypoxia. Well, if the tube is in the stomach and she's not breathing for herself, she's going to become hypoxic. Not only that, but as you're bagging and causing gastric insufflation, right? You're filling that stomach with a bunch of with air. You know, that can cause irritation to your vagal nerve, cranial nerve 10. That can cause bradycardia. So you have this bradycardic induced asystole, basically. So she codes, right? So, okay, so she codes. They start doing compressions. I think I started doing compressions. Like, okay, she's coding. We're doing no. I take that back. I did not do compressions. That was a different story. So I'm watching this unfold, and oh gosh, so I'm at the foot of the bed watching this, and she codes. They start doing compressions, and there's so many people in the room, right? You're in the ER, so there's like 10 people in this room, you know, and I think I was trying to put on the 12 lead as all this was going on, possibly. I don't know. I was at the foot of the bed. I was probably trying to put on the 12 lead. Anyways, so you got like 5 nurses in there, a doctor, a bunch of techs. Everybody's in there. This is the most critical patient right now. And so as she codes, of course, what's the first line of defense for a full arrest? So, I mean, epi, you're going to give a whole code 1 milligram, 1,000 microgram IV bolus epi. Boom, slam. Someone slams a whole tube of epi in, like instantly. Like, oh, slam it in, right? And as she's slamming in the epi, the dude doing the compressions, I don't know why this was happening. And oh gosh, it really still bugs me to this day. So this guy doing the compression was like 6'6", skinny, tall dude, nurse. And, you know, he kind of had like an ego about him. I don't know why. He always had an attitude. Just kind of rude and just kind of sour. And he was young. He wasn't even like a salty nurse. He was like a young nurse. He just had a bad attitude. And for some reason, he decided he was going to do the compressions as deep as he possibly could. So dude's like 6'6", and he's doing compressions on this little lady. She's like 5'4" or something, a little lady. And he's doing the compressions, no joke, like 5 inches, 4 or 5 inches, like compressing, like her chest wall was like clamping into the bed. I was like, dude, why are you trying to push her heart through the back of her chest wall? I mean, I didn't say that, but I was like, are you going a little bit deep? And you might be going a little too deep on your compressions. I said something. What did I say? I was like, oh, yeah, I think I said you're going a little deep on your compressions. And he like stared daggers at me. Like, don't tell me how to do this, you know? And so this is all happening where he's like compressing the crap out of this lady's chest. And then the code epi gets pushed. Now remember, she's on the heart monitor as the code epi gets pushed. Code epi gets pushed. This lady, so this is a stroke patient. Come to find out later, this is a hemorrhagic stroke patient. And so he's doing these compressions that are just basically like, well, I don't know, dude. I've never seen somebody chest goes so deep into the bed. So he's doing these crazy deep compressions, and then we slam this code epi, and her heart rate is at like, I think 249, and it like just ramps up to like 249, 250 with this code epi for sustained for like probably like 3 or 4 minutes. And then we get a blood pressure. Oh, we got a heart rate. Oh yeah, you got a freaking heart rate. Yeah, of course you have a heart rate. You just, this heart is fine. It just needs a little oxygen. Just give it some oxygen, and it's going to come back. Anyways, so blood pressure is like, I think like 225 or 235 over 150, some stupid number. And when you have somebody with a hemorrhagic stroke, when you push code epi on a good heart that's bleeding in her brain, and then you increase the pressure, to 200 something, 230 or something over like 160, and it's pumping at 250 times a minute. I mean, dude, I was looking at this. I'm like this poor lady. So they take the tube, they retry to set the tube right, they get the tube in properly, and they take her to CT. What do you know? She freaking herniated through her foramen magnum, like completely. There was a mass effect. This massive bleed just herniated her brain. She passed away, of course. And like how many goof ups can you do in one case? And I feel like it's kind of, the story kind of highlights the dark side of EMS, or the ER, I guess. Bad things can happen in any unit, but the worst things happen, I think, oftentimes in the ER. That's my personal experience. It's just becomes just such a cluster where, it's just sad. You're like, okay, so many things went wrong. That could have been maybe avoided. Now, hemorrhagic strokes don't normally have good outcomes anyways. She probably would have had a really bad, prognosis. She probably wouldn't, even if they were able to go in there and, clip something, or, stop the bleeding. And, generally there's deficits. People have deficits, and they're never the same. So it's not, maybe it was, I don't know. I don't know if it was better that happened. Of course it was meant to be, because that's just the way it is. I don't know. But, watching it unfold and understanding the why to what's happening helps with clinical decision making. So like, if the patient is asystolic or having a PEA arrest, it's a good idea to go through the H's and T's. I'm not saying don't slam epi. If they need epi, slam the epi, right? If they need it, give it to them. But sometimes, not always, but sometimes a little less is more. Sometimes. And I've been in codes like in the cath lab where, I'm losing my pressure, and I have some code epi, but I'm not going to freaking slam a whole milligram, right, of code epi on this heart to keep the pressure up. I'll give a bump, right? I'll give 100 mics, a little 100 mic bump, or IV. If I have levo going, I have dobutamine going, and I've given some, phenylephrine, right? I've given 200 mics of phenylephrine, and pressure's not coming back. Okay, I'll give maybe 100, like 100 mics, dude. 100 freaking mics of epi is hardcore, dude. Your pressure is gonna be like 200 over 150, and your heart rate's gonna jump up to 175. on a 100 mic slam of epi, even on a bad heart, you're going to get a response generally from it. So it's not, it's, the difference between slamming a milligram and slamming 100 micrograms of code epi. Now, I'm not saying in the ER you can really do that because you're not running the code the same way in the cath lab. In the cath lab, it's different because I have a pacer, I have fluoro, I have a root pressure, an aortic root pressure through the sheath. I have, way more IV access. I have just way more resources available to know, hey, at this pressure or where we're at right now, I don't need to slam the whole amp of epi, right? In the ER, you can't know all that information because you're not in the cath lab. You don't have the same information coming at you quickly like that. You're kind of guessing because you don't have all the information. You don't even know this person's name. Person showed up. And it's like maybe one person in that room knows the name. It's probably registration. Registration knows who this is. Where's the armband? I don't know. I don't know where the armband is. I don't know what the allergies are. I don't know past medical history. I don't even know chief complaint. But we're gonna get the blood pressure and we'll go from there. That seems how it is in the ER. You just kind of roll with it, like whatever, which is fine. That's the part of the game, right? That's just part of how it is. I wonder how I can get rid of all this echo. If it's still echoing. Is it still echoing? I don't know. You know what? I'm not going to worry about it. I don't care. Sorry. I just don't care. There's nothing I can do about it. There's nothing I can do about it. So, I mean, there probably is something, but I don't know. I can feel the echo in my area. I can feel it, but that's the way she goes. So how long has this been? What am I at? I'm at 22 minutes. It's a good story time. It's a good story. So if you made it this far, that's kind of cool. Yeah, so I'm not working right now. I've gotten 2 weeks off out of 6. I get 6 weeks off right now. So we just had our third girl. We have 3 daughters. So she's 2 weeks old. So I'm on paternity leave. I've been making a garden in my backyard. I made a little raised bed garden. And just pruning my fruit tree out in my front yard. I got a little apple tree I was pruning and getting ready for the season. And I've just been kind of enjoying my time. I haven't been studying, really. Just been enjoying my time. So that's my story time. Nice little Code Blue story time. I got a bunch of other ones. I'll do another Code Blue story time next time. And yeah, I think that's all I got.